And welcome to today's webinar. It is the last in our series of on diabetes. We have Dr. Jacob Kornberg here with us, who completed his medical degree and his 4-year surgical residency at the University of California, Irvine, and is currently the Director of Professional and Clinical Services at the Metagenics Functional Medicine Research Center in Gig Harbor, Washington. Dr. Kornberg?
Well, good evening or good afternoon, depending where you're listening to us. Very much for joining us, and this is the final chapter in this unique perspective of our diabetic patient. Over the 3 webinars, we've discussed vascular risk of this patient. We've discussed male health and his problems with erectile dysfunction and vitality and low libido. Last week we looked at the 4R program, addressing some of this patient's GI symptomatology, and going to take a close look essentially his initial disease, which brought him into our clinic, diabetes. This 63-year-old African-American male had a 16-year history of type 2 diabetes, and he presented for enrollment in our trials, our diabetic trials, at the Functional Medicine Research Center here in Gig Harbor. He was maintained on human insulin and was checking his blood sugar 3 times a day. He was not following any specific dietary recommendations. He had been at a normal weight until approximately 3 years ago, when he gained about 50 pounds. At the same time, 3 years ago, he noticed to have an elevated blood pressure and was started on antihypertensive medications. Was led by his company 3 years ago when his company downsized, and this has put a financial strain on the family, and he's also taking care of his son with autism, which causes him about 8 out of 10 stress. Other concerns that we found was obesity, arthritis, benign prostatic hyperplasia, and dysfunction. He had indigestion and heartburn, which he wears podiatric devices, and neuropathy in his feet. His social history: he's not following any specific diet. He exercises, but is not exercising at the present time. He had smoked for 20 years, but had quit about 20 years ago, so he has a 20-year packed history. He does not drink alcohol, but drinks 1 cup of caffeinated coffee per day. Past medical history: he had his rotator cuff repaired. His father has a significant history for type 2 diabetes and cardiovascular disease. His mother had hypertension and obesity. His birth also followed in his father's footsteps with cardiovascular disease, hypertension, obesity, and prostate cancer. And presently taking insulin 50 units twice a day, metformin to try to control his diabetes, Kimarin, which is a angiotensin II test for his hypertension, Atal, which is a beta blocker for his hypertension. He occasionally takes acetaminophen and sildenafil, which he uses for his erectile dysfunction. His physical examination: he's overweight. The BMI is 36.2, and his blood sugar at this time is normal, but his weight to hip ratio was elevated at 0.95. His physical examination was essentially unremarkable except for being overweight. His laboratory work shows he has problems with his lipids. He has elevated cholesterol at 210. Triglycerides are markedly elevated at 264. His HDL is low at 32. His calculated LDL is within the normal range. His total cholesterol to HDL ratio is too high at 6.1. And his triglycerides to HDL ratio, which is an indication of metabolic syndrome, is markedly elevated at 8.3. We also have liver enzymes, and although they're within the normal limits, it's interesting to know that his ALT was at the end of normal, and GGT was also at the top end of normal, and we'll come back to the significance of that in a few minutes. Laboratory work shows his high sensitive CRP has come down a little bit from the initial at 2.0. He's at low vitamin D at 19. His fasting glucose is still 111. His globin A1C is elevated at 6.9. Fasting insulin is high at 28. His albumin excretion is 32 micrograms per minute. Give microalbuminuria, and we'll come back and talk about that. And as we saw last time, he had positive fecal anti-gliadin antibody of 17, showing that he was gluten sensitive. The rest of blood chemistries was normal. So, treatment options that we're going to discuss about from point of view would be same first-line therapy. We've done this in all three of our protocols because we believe that the environmental impact is significant. So he's on a modified Mediterranean, gluten-free, low-glycemic, anti-inflammatory food plan. He'll be doing exercise, stress reduction. We're going to give him a combination of 4 specialized formulas to help support male health and vitality. We'll give him one of our new medical foods called Glycemics 360, 2 scoops twice a day. And then if we still cannot get his fasting blood sugars or his 2-hour postprandial blood sugars under control, we're going to add a fermented black soybean tea extract, 1 tablet, 30 minutes before meals for his meals. Additionally, we'll continue with the vitamin D, 5,000 units a day, high concentrated DHA, and CoQ10, 1-3 tablets per day. But continuing our story, we need to remember that this whole process of developing type 2 diabetes is continuum. On the left-hand side, you start with a healthy body which is insulin sensitive, then you start developing borderline insulin, and metabolic syndrome is where you have insulin resistance but it's compensated, which means that when you look at the blood sugar, the sugar may be normal, but insulin level to a fat is much higher than normal. Until you come to non-compensated insulin resistance, and this is where the blood sugar starts rising, insulin levels also elevated. Okay, the bills broke compensation do not have insulin reserve, and so here what we see is an elevated blood sugar with actually a decreased insulin to that the patient may need to take supplemental insulin. Just behind us, metabolic syndrome is any 3 of these 5 components: an elevated waist circumference, which he had, elevated triglycerides above 150 or on drugs, which he had, a reduced HDL. It's a little different for men than women, and he had a reduced HDL. His blood pressure now is normal, but he's on drugs for hypertension, so he would have this component, and an elevated glucose. His elevated above 100 on medications for glucose. You want to remember the consequence of metabolic syndrome. We've already talked about all the various diseases, but I believe this is the gateway to diabetes. I love this cartoon. It really was an insulin. You don't have diabetes yet. This was just a warning shot. And so, sort of the takeaway is that if we can prevent metabolic syndrome, it's a lot more than a pound to cure, which we have to try to do once a patient develops diabetes. This diagram, Klinefeld, just shows you again this continuum. You start with genetic factors and acquired environmental risks such as obesity and age. As we start at the top, there's a low risk for cardiovascular disease on the right-hand side, maybe genetic predisposition, but no evidence of diabetes. And as we see that we end up with postprandial hyperglycemia, meaning after we eat, our blood sugar goes up, we increased insulin resistance, the hyperinsulinemia, feed back into this loop, so we get glucose toxicity, feeds into decreased insulin secretion, and you can see these 2 feedback loops until eventually we get insulin resistance goes up, and we start seeing from glucose toxicity, beta cell dysfunction. We then with constant hyperglycemia, which leads to eventually chronic insulin resistance, eventually complete beta cell failure, and the need for insulin. I can see the risk of cardiovascular disease on the right goes up, and we start going from thought was a normal person with this genetic disposition to prediabetes to eventually full-blown diabetes. I predicted that over the next 30 years, diabetes will claim 62 million Americans. It's just a very interesting map, a little bit busy. I hope you can see it, but it shows in 2003 versus 2025 the increase in the global prediction for diabetes. Now, there in the left upper corner, North America, and we don't go up very much because we are already way ahead of the curve in our rate of diabetes. But you see places like Africa, Southeast Asia, in Middle East, they're going to go up over 100% in the next 20-some years. So diabetes in this epidemic is definitely a global problem. If we do not do something to stem this, it will be a financial disaster to many of the health plans. So let's find type 2 diabetes. We have two types, type 1, and that's where we have beta cell destruction leading to insulin deficiency. And there's type 1A, which is from an autoimmune approach. And type 1B is idiopathic, meaning they don't really know the etiology. It's very rare. Type 2 diabetes is characterized by this continuum of insulin resistance, impaired insulin production, glucose into the muscles, and increasing serum glucose. Diabetes may require insulin or not, but almost all type 1 diabetic patients require some amount of insulin. So diagnosis can be made by a fasting glucose level greater than 126 milligrams per deciliter, or a plasma glucose greater than 200 milligrams 2 hours after a 25-gram glucose challenge. We call this a glucose tolerance test. And you look at this test, you can see normal curve on the bottom, which if you look at the 2-hour level is around or below 110. An intermediate called impaired glucose tolerance until you get up greater than 200, which is represented by the green curve on top, and this insulin-dependent diabetes up there. So we can use this glucose tolerance curve to diagnose diabetes, and the term area under the curve is used a lot in research, and we'll refer to that later on. Or, to make diagnosis, you can have symptoms of hyperglycemia and a random single plasma glucose greater than 200. This from the World Health Organization. And if we look at the various symptoms of diabetes, you can see that you can get increased thinking. With type 1 diabetes, you might get lethargy and stupor. Sometimes you can smell, and when people become ketonic, you can smell an acetone on their breath. From the gastric, you can get nausea, vomiting, abdominal pain. This is more common in type 1. In both types, you get an increase in urine frequency called polyuria, and when you stick this, they have an elevated amount of glucose they're spilling in their urine. And the respiratory in type 1, when they have an elevated called Kussmaul breathing, where they're hyperventilate to try to blow off CO2 from acidosis, and type 1, they can be a reason for weight loss. So any one of these symptoms, then with the glucose of greater than 200, could make the diagnosis of diabetes. And the last, more recent one is a hemoglobin A1C greater than 6.5. So these are tools. These are the laboratory tests that we would use to diagnose diabetes. Interesting from this article that the evolution and remission of type 2 diabetes is continual. People go from a normal glucose into a pre-diabetic state and back and forth, and then from a pre-diabetic into type 2 diabetes, and then they can go back into it. Classic is when somebody has gestational diabetes. They can go back into what they call a pre-diabetic state or even normal glucose. And this article thought it was about 30 or 40% of people go back and forth. Our experience is probably higher rate of pre-diabetics end up becoming diabetic. What makes the continuum or the pendulum swing back and forth is whether you have pro-diabetic factors on the left, obesity, inactivity, and pro-diabetic medications, a poor diet, aging, and other medical diagnosis add to this, or whether you start doing some anti-diabetic factors such as lose weight, increase your physical activity, maybe have a medication, or with a low glycemic Mediterranean style diet. Confusing. Essentially what it says is that when you have hyperglycemia with diabetes, it creates a lot of reaction in the body. You can get reactive oxygen species or reactive nitric oxygen species. You can get advanced glycation end products or upregulation of their receptors. And on the left, you can get various types of kinases that are upregulated. But essentially what this upregulation of these intermediates do is create inflammation. They create damage and interfere with the histone metabolism and proper DNA reading. This leads to altered epigenetic and altered chromatin modifications of the patient's DNA. Leads to abnormal gene regulation in his tissues. When leads to kidney disease, maybe cardiovascular disease, and all the other diabetic-associated complications. The article just talks about advanced glycation end products having an adverse effect on end organs, and pathogenesis of diabetic complications is probably a relationship to these advanced glycation end products that are produced as a result of one, either the innovative glucose or food we take in that already have these advanced glycation end products with them. But just kind of reiterates that this post-parental glucose elevation is really critical in the management of diabetes. We need to get it down. And the immediate post-parental glucose elevation can account to as much as 40% of glucose load day. And it seemed to be linked, as we saw in the slides before, with oxidative stress, increased reactive oxygen species, and increased risk of cardiovascular events, even in non-diabetics. So a low glycemic Mediterranean type diet is not only good for diabetics, but for all of us. Look at the clinical impact of diabetes. There's a 2 to 4 time increase in cardiovascular mortality. And this will just give you a great sample of all the various things from any type of cardiovascular event is increased. The number one would be the risk if you did not have diabetes, and you can see the increased risk going all the way out to almost 5.5 with intermittent claudication on males. And it's kind of interesting that you can see that the claudication is very high in males, where cardiac failure is very high in females, and the amount of MIs seems much higher in females with diabetes, and coronary deaths are almost twice as high in females as in males. So although we're talking about our male patient today, females are at really high risk for cardiovascular mortality with association of diabetes. This article just again talks about the increase in myocardial infarction with people with type 2 diabetes. On the left, they have no prior MI, and you can see the marked increase in 7-year incidence. And then on the right, even if you had a prior MI, it's almost 2.5 times to be a person without diabetes. When you get the total group of people with diabetes, again, cardiovascular disease is only about 65% of the cause for mortality. So next, it's the leading cause for end-stage renal disease in our country, and we showed this slide earlier, but close to 4% of people with kidney failure come from diabetes, and the other 30-some% from hypertension, what this patient had. We talked about microalbuminuria on our first webinar, but just want to refer, because it's so important, that microalbuminuria indicates renal endothelial permeability and dysfunction. Detection is especially important because it signifies early damage long before you actually see change in renal function. And have shown that microalbuminuria is an important independent marker for endothelial dysfunction in cardiovascular disease in diabetics, but in people with hypertension. Pressure memory again, the doses of microalbuminuria is this exhibiting the normal, which is lower than 20 micrograms per whatever you're measuring, depending on the 3 different parameters, or 30, and what we call macroalbuminuria, which is over 200 to 300, depending what you're measuring. And this in between, we call albuminuria, and you have to actually turn it off. It's not done as a normal urinalysis, but you have to ask for microalbuminuria test when you request it. And again, we showed this last time, or the first seminar. It just shows you that with microalbuminuria, there's an increased risk of ischemic heart attacks as your blood pressure goes, systolic blood pressure increases. So the index of diabetes it's the leading cause for blindness in working-aged adults, as opposed to like macular degeneration, and the leading cause of non-traumatic amputations in our country. As a surgeon, unfortunately, I took care of people who had to lose their extremities. So I guess the key here is eye examinations are critical to have with patients with diabetes, to look at the retina and make sure there's not early changes, and also it is imperative that all of us have the patients remove their socks with their feet, and have the patient examine their feet, because sometimes neuropathy will allow the feet to become somewhat numbed, and they will not see or feel ulcer that may be developing on the bottom of their foot. So at the distribution of the cost of diabetes and managing the complication, you can again see that the cardiovascular disease is over 50%. Kidney failure and the need of dialysis is 20%. Neuropathy and retinopathy make up the last 27%. Now, a little bit about persistent organic pollutants, because this comes into the literature recently. Just that little square box, if you remember, our patient had an elevated BMI and he had slight high normal GGT. In this very interesting article from Lim, it's about the relationship. We always thought the BMI, if you had an elevated BMI, you were going to end up with diabetes. But he actually said no. If you have to look at other component, and he looked at a GGT as a liver enzyme being a function of liver stress related to persistent organic pollutants that are ubiquitous in all of our bodies and in all of our environment. He showed that if you have elevated BMI and how normal serum GT this will be with an increased risk of diabetes, but if your GGT was low normal, it's not. So let's put this little picture down here that it's just obesity, but a B plus organic pollutants, which Dr. Bland calls angry fat, which equals this increased risk of diabetes. There's many articles now showing that the bisphenol A from plastic leaching out in bottles is elevated, and indicates increased incidence of cardiovascular disease, type 2 diabetes. There's also there's a lot of articles talking about persistent organic pollutants, and when they are elevated in the serum concentration, you get an increased prevalence of type 2 diabetes. This is a very interesting article, of course, from Vietnam War, showing Agent Orange. The herbicide used in the Vietnam War is increases the risk of diabetes and genic, and we're seeing this in our Vietnam veterans. And this is a very interesting article. This is an article from them again, talks about a pesticide called atrazine, which is used in the middle of America for corn. And they show that this atrazine contributed to the development of insulin resistance and obesity by itself, especially when there was a high-fat diet. And the summary was that it's interesting that atrazine was started to be used in the early 60s, and this was the beginning of the present obesity epidemic that we've seen. And if you compare the use, these two curves parallel. And this product found in our it's not washed off, and they even put up the possibility that it would be atrazine residue in high fructose corn syrup that may actually be causing the association with obesity. Interesting kind of theory. Also, remember that heavy metals will decrease of not only cardiovascular disease, but diabetes and kidney disease, especially arsenic for both males and females. And we showed this article last time from Meta. This shows that when they injected toxins for gut in normal, healthy adults, they created insulin resistance without affecting the beta cells in the pancreas. So there's a lot of literature now saying that anemia, whether it's from inside, like endotoxins, or outside, like pesticides or persistent organic pollutants or heavy metals, they havoc with our insulin signaling and maybe one of the orchestrators of this epidemic of meta syndrome and type 2 diabetes. When we look at the response of messengers from inflammation, we've looked at this before, but just as a refresher, it impairs insulin signaling. Remember that inflammation decreases PPAR gamma. PPAR gamma is needed for the GLUT4, which is the glucose transport molecule, to come up. So with inflammation, we have increased insulin resistance and decreased insulin signaling. We have poor glucose utilization and glycogen storage. We have increased glucose synthase kinase activity, which also is a direct inhibitor on proper insulin signaling. Our fat cells swell, creating adipokines, so the fat becomes a generator of inflammatory messengers to signal the peripheral tissues to store fat. And of course, the inflammatory cytokines plays havoc with inflammation both systemically and localized. This on the peripheral tissue, as that we get increased fat storage. Some subjected to inflammatory substances, cells in our peripheral, especially muscle, become insulin resistant and will not take up the glucose like we should, fat stored in adipose tissue. So we got a decrease in increase in muscular fat. Intrathecal fat goes up, subcutaneous fat goes up, and there's that. Adiposity is a hallmark of insulin resistance. So, management of type 2 diabetes and metabolic syndrome. Those are talking about lifestyle changes should be the main approaches. Body improvement, diet, and of physical activity. These are the main approaches to prevent patients, treat and prevent type 2 diabetes or metabolic syndrome. This article just showing the two curves showing lifestyle interventions on the top, and a control group on the bottom. And this is the probability of developing a cardiovascular event, and you can see that it was much lower in the intervention group, and for diabetes also. In this, compare lifestyle to metformin. Lifestyle intervention reduced the incidence of diabetes by 58%, in metformin only by 31% as compared to the placebo, and their study was that lifestyle intervention was more effective than metformin in preventing diabetes. Lifestyle change programs are as effective as insulin therapy on poorly controlled subjects with type 2 diabetes. Life change programs prevented weight gain associated with type 2 diabetes, and the change programs has a beneficial effect on these fat-generated inflammatory markers on these patients. Of course, with lifestyle change programs from this Gallup poll, that when they ask how many different times if you tried to lose weight, you can see that the number of times that people have attempted a program to lose weight has gone up and is continuing to go up because it's difficult to do on your own. Like we before from Esposito just says that these type of lifestyle programs require structured patient education. You can't hand a patient diet or a Mediterranean diet sheet and say, here, follow this diet. They need education, they need encouragement, and they need something similar to the first-line therapy approach. The patient was put on, as we talked before, a 5 Mediterranean diet or food plan because he was gluten sensitive. It's gluten-free, low glycemic, anti-inflammatory food plan. He was started on exercise and purposeful eating, and we addressed his stress problems and helped him with his sleep. This recent summary article from this year from Eisen just looked at the study from the Mediterranean type diet in this research led to beneficial change in the population of overweight patients with newly diagnosed type 2 diabetes. So, although this type of recommendation was started at the beginning of 2000, it's continuing to be a recommended diet approach even in 2010. Again, from Esposito's work, when compared a low-fat, low-carb diet to the Mediterranean diet, They showed more favorable changes in glycemic control, cardiovascular risk factors, and a need for anti-glycemic drug therapy in overweight patients with newly diagnosed type 2 diabetes. This is an interesting article that just came out this year from the British Medical Journal, and when they looked at specific leafy green vegetables, this article says maybe the benefit is in leafy green vegetables, and they did not see the same effect with fruits and vegetables. So the summary was increasing daily intake of leafy green vegetables could significantly reduce the risk of type 2 diabetes, and they thought it should be investigated further. So we tell our patients they have to have at least one large salad per day with dark leafy vegetables, and within it 2 different colored vegetables. Now the plan of first-line therapy, we've talked about it. We treat our patients up to 150 minutes of type of exercise per week, and we work on mind, body, spirit practices to reduce stress and decrease inflammation. Now, very briefly, for convenience, put this patient on a 2-day pack of for health for men, and just a convenient way of him. We talked about the tribulus before as thing with male sexual function and vitality. So it has 4 tablets per day. It has already the EPA DHA, high concentrate in it. It has good multivitamin content without iron, at least 2 tablets per day. And it has zinc chelate, which helps with prostate health, so energy metabolism, and in function, 1 tablet a day. So these 2 packets just make it convenient for a patient to take 1 in the morning and 1 at night, and they get a round foundation for this man's particular need. There's also another packet that's aimed at helping people with glucose problems, but since we're going to go to a medical food, I went with the Vitality packet on our gentleman. So new product, Glycemic 60 medical food. He would take 2 scoops twice a day. And this is a medical food that is what we've talked about before. It's based on Ultra Meal Plus medical food, 360 medical food. So it has the RIA, the isoalpha acids from hops that we've talked about before, that has improved insulin signaling and decrease inflammation. And we've seen this picture again of the kinases from RIA, just showing that there's selective kinase response modulation of decreasing specific kinases that interfere with insulin signaling, and these are the inflammatory kinases within the product. Also talked about before the acacia nilotica extract, but also decreases kinases are responsible for inflammation. These 2 products were combined, as you remember, in Ultra Meal Plus 360 to give us this new class of therapeutic agents which modulates insulin signaling and decreases inflammation in a very tissue-specific manner. Again, several of the insulin kinases that are needed to improve insulin signaling. Remember we talked about glycogen synthase kinase before, that it's upregulated. Well, this helps decrease it. It kills many of the kinases. And this is just the research out of our lab showing the human trials. You can see a 2-hour postprandial glucose is markedly decreased by using the RIA acacia combination, along with 2-hour postprandial insulin on the right. When we look at triglycerides, which our patient had an elevated, this combination showed marked reduction in triglycerides using the RIA acacia combination. And when we compared this to 2 other products, increasing on the top serum glucose, on the bottom serum insulin, and actually these products right here is metformin, and this is rosiglitazone. But you can see that the Rhea Acacia blend did very well, and comparatively, there were statistically no significance from pharmaceuticals to decrease serum glucose and decrease serum insulin. The product starts with the base of this Ultra Plus 360. It's designed for those patients with type 2 diabetes. It improves glucose and insulin signaling and glucose levels, decreases cholesterol and triglycerides levels. A low glycemic formula, so it's a great way to start the morning. It then has 15 grams of a non-genetically modified soy protein. Remember, soy protein itself improves cholesterol metabolism, both in the gut and in the liver. It has the Rhea, the skirms, to improve cellular signaling, and the Acacia Nicotila Niloteca, both shown clinically to improve fasting insulin and triglyceride levels. 2 of plant sterols per serving, and the NIH recommends at least 2 grams to promote healthy cholesterol levels. And then we added to this specific nutrient support for a diabetic patient. First, we all know the results on cinnamon. This was an inclusion of at least 2 grams of cinnamon in the diet. People with 2 diabetes will reduce the risk associated with diabetes and cardiovascular disease. So cinnamon was added to this product. Here we have chromium and biotin, show they decreased the hemoglobin A1C and fasting glucose levels reduced in patients that without any adverse effects. So chromium and biotin were added to this product. So this not only has essential vitamins and minerals needed for proper blood sugar control, but also added the green tea catechins to protect the cells. Again, the cinnamon, the chromium, and biotin. We added alpha-lipoic acid, an antioxidant scavenger of those free radicals. As you remember, one of the first slides that showed all those various reactive oxygen species and those various actants causing genetic damage. So the alpha-lipoic acid acts as our room, sweeten up these radical compounds, and it provides antioxidant profile to help reduce oxidative stress and promote healthy insulin action. So I put this down here, but again, this fermented black soybean tochi extract is really used as augmentation to a program when the above 3 have brought the postprandial glucose under control. So what I would do is I would first start the glycemic 360 medical food and monitor the blood sugars, and very, very good luck, good results here at the Functional Medicine Research Center on helping people to actually decrease their insulin requirements. But the fermented black bean tea extract works like this. In digestion of carbohydrates in the body, alpha glucosidase is needed to break down the complex carbohydrates in glucose and fructose, so it can be absorbed by the body, and this causes increased blood sugar. Well, several pharmaceutical drugs that block the alpha glucosidase, and this prevents the glucose from being cleared and broken off the complex carbohydrates, and it decreases the absorption of glucose. So it decreases that postprandial area under the curve of glucose. Unfortunately, most of these drugs create increased gas and diarrhea in patients that take them. So how these work, and drugs block the final breakdown of the complex starches and sugars, so it's less glucose, less fructose, and eventually a lower blood sugar level. While fermented black soybean toast extract is recommended in some of the texts on natural medicine, has been used in Asia, great success, and it works very similar to the alpha-glucosidase inhibitors, but it's not like natural product. It's not a complete knockout of this enzyme, so you don't get the side effects. Same effect, it decreases glucose, decreases fructose, and help decrease blood sugar by decreasing the glucose and fructose available to the intestinal lining for absorption. And here are some studies just showing that it, in the rat model, it a significant decrease, total triglycerides and cholesterol decrease, and in the human studies, just showing that there was a reduction in glucose area under the curve with the glucose tolerance test, and in type 2 diabetes with 100 milligrams of toad extract, again, a reduction in glucose under the curve. So as we close here, we want to just look at a few additional options. We talked about vitamin D on this patient because of the low vitamin D, and just to remind you that low vitamin D predicts coronary mortality, predicts strokes. It's important in inflammation and autoimmune disease, so we want to bring his vitamin D level up. We want to get high concentration of DHA. Now, he was already taking EPA DHA twice a day, and I decided to give him an additional amount of DHA. The literature shows that it increases HDL and LDL particle size, and that's done by DHA, not EPA. Decreasing triglycerides with both. Decreasing heart rate, blood pressure, and platelet aggregation seems to be mainly a function of DHA, not EPA. We taught increasing inflammatory markers. It supports the immune system, gut, and nervous system. It's manufactured from sustainable squid source, so it's okay for people with fish allergies, and it's certified to be free of any pesticides or heavy metals. So we have patients with an elevated risk of cardiovascular disease. I like to give them a little extra amount of DHA in their diet. CoQ10 we talked about also in a previous webinar, but study just reviewed 34 control trials and showed that supplementing with CoQ10 prevented cardiovascular disease through the inhibition of LDL cholesterol oxidation and by maintaining optimal cellular and mitochondrial function throughout the range of time and internal external stresses. And we showed that attaining a higher blood levels of CoQ10, uses of higher doses of CoQ10 enhanced both the magnitude and the rate of clinical improvement. So in this patient, we might want to go to 200 to 300 milligrams of CoQ10 a day to try to help prevent cardiovascular events. Because if you remember from our first webinar, he had over 37% the Framingham risk score of developing a cardiovascular event in the next 10 years. So the goals for diabetic management are trying to get glycemic control. Under 7 by the American Diabetic Association, or under 6.5 by the American Association of Clinical Endocrinologists. We want to control hypertension, control lipids. People who have had a risk of cardiovascular disease, we may want to start on something such as aspirin every day, or we want to add a product that we have, maybe a Thea product to decrease inflammation. And of course, if patients are a smoker, we want to have them stop smoking. So, ode to of life can lead to type 2 diabetes. So if our patient has healthy body composition, but then with poor choices, we eventually go to an altered body composition where we have central obesity and early insulin resistance. And we've talked about using Ultrameal or Ultra for this type of condition. The patient pay attention, continues on the road of good life, now hyperinsulinemia. He now has increased triglycerides and hypertension, the cardiometabolic syndrome, and talked about adding Ultrameal plus 360 to this person's diet. But again, if the patient doesn't pay attention, actually goes to type 2 diabetes, has elevated blood sugars, elevated hemoglobin A1C. His is now changed, and we would recommend our new product, Glycemic 360 medical food for the type 2 diabetic. So in summary, our treatment plan, first-line therapy, a convenient pack twice a day of essentially some vitamins, tribulus, some essential fatty acids, and zinc. Put them on the new Glycemic 360 medical food, 2 scoops twice a day. And if needed, we would add the fermented black bean tochi extract, again, before meals, about 20 to 30 minutes. We added vitamin D, concentrated DHA, and at least twice CoQ10, maybe 3 times a day. So that's the summary, and I thank you very much for your attention. I know there was a question last time, which one would you start on? It's been very fun me presenting the 4 different perspectives of these patients, because what I found, when you start with the beginning, when you start with the environmental influences on this patient through diet, stress reduction, and exercise, you're halfway there. Depending on what you think are the most critical issues, and as remember, we talked about his cardiovascular risk first, start there. And control his triglycerides, and you bring down his cardiovascular risk, we went to his mental vitality issues. You move on to his gut issues. And finally, since he's really well controlled, we talk about his diabetic issues. Glycemic 360 medical food can be mixed and matched and used with other products. So this is sort of an art of medicine. There is no absolute right way. Again, thank you very much for listening, and I think we have time for questions, Irene.
Hi, yes, Dr. Kornberg, thank you very much. This is Inez. We have a few questions
Inez, sorry.
for us here. No problem. So the first question is, what can be done for a menopausal woman whose fasting blood sugar is 99 while on a gluten and dairy-free diet with no starchy carbs and adequate protein? She's diagnosed with Hashimoto's, which was treated with thyroid meds. She still suffers from thyroid SX, it says here.
Okay, so this is a menopausal woman, blood sugar too high. I would, in my experience, the reason I put in that this patient was gluten sensitive, because I have seen that as an underlying cause for inflammation in many patients. And so I would test this patient. I would put this patient on an elimination diet. That is, and we've talked about this before. My food to go to is my Ultra Inflammix. I love that. But my therapy to go to is my elimination diet. I would put the patient on an elimination diet and recheck the parameters. And, I think there's a high probability that you'll see an improvement in glucose, and then the matter of fact is try to figure out what is bothering the patient. I've found that patients that go on an elimination diet many times have marked improvement in their menopausal symptoms. The other place to look at is stress. may or may not be addressed. Stress through elevated cortisol will elevate glucose. So the two things that many times we forget to look at, and I can look at that.
Thank you. Okay, so we have another question. So specific products today would only be utilized for the type 2 patients. When would you be able to tell when complete B cell destruction has occurred, since there isn't a test for this? Is it just trial and error?
Well, there is. There's different types of insulin. You check that the C12 insulin, I think it is made. If my slide said for the type 2 diabetic, I probably was incorrect. This can also be used very successfully in type 1 diabetic, and what we've done is by using this and the diet approaches, you're able to reduce the amount of insulin, and many of the patients I have found are what we call, they're kind of brittle. They have a hard time controlling their insulin levels. And you put a patient on the same type of program. In other words, you might use, I would definitely use a Mediterranean diet. I would definitely, on a type 1 diabetes, treat him on elimination or at least a gluten-free diet, or at least check that. Low glycemic diet, you have the glycemics 360 medical food. You may or may not add the tree extract. And what you find is sudden their insulin levels lower, and the swings become much less, and their daily glucose measurements be stabilized.
Very good. Thank you. What is the exact amount of DHA that you would give a patient per day?
The exact amount of DHA I would give per day. Well, if I'm dealing with a cardiovascular patient, literature shows that between 2 and 3 grams a day cardioprotective. That I would at least have to be DHA. I talked about this way back in the beginning, that you can measure the omega-3 index of a blood cell by submitting what we call the omega quant test. The test, your Metagenics representative can help you with that, because we distribute this test. It's very easy. The patient just does a stick, puts a drop of blood on a filter paper, mail this in to Dr. Harris's lab, and he will actually print out the percent DHA that you should have. And the literature shows, now it hasn't been done necessarily for DHA, but you want to get this above 8%. So that's what I actually use that clinical endpoint as a way to fine-tune. In a cardiovascular patient, I'm trying to get half of my daily DHA, omega-3s as DHA. For a very short question, so I hope that clarifies it.
Thank you. Has FLT produced any specific handouts related to diabetes with a guide for consistent carb intake for each calorie level?
I do not think they have created, now I may be wrong, it may be in the works. I've not seen a specific guide for diabetic patients. What is interesting is that if you saw those articles from Espinito and several others, people are getting away from calorie counts. And when compared to low-carb diets, the concept of a Mediterranean diet is more the right kind of carbs, i.e. not refined carbs, and very complex carbs, and a lot more green vegetables than fruit. And the right kind of fats, not a low-fat diet, but omega-3 fats, and the right kind of proteins are actually making more sense and having more influence than any specific diet where you try to measure and decrease a specific single nutrient. So the literature is moving in this direction. Probably won't see FLT come out with a specific carb count. I think that is as important as the type of carbs the patient eats. I've not been doing carb counts at the Functional Medicine Research Center, and we've been getting very good results with our 2 hours perennial blood sugar. A couple other things. Bringing up a couple little things I've noticed. In the morning, blood sugar to be higher than the hour post-perennial at dinner time. I mentioned this before. Look for sleep apnea. Look for some type of stress that is going on at night that creates elevated cortisol and elevated blood sugar. Because the body, after 12 hours of sleeping, should actually have a lower blood sugar than they after 2 hours after a meal. Finding that in your patient, look for other causes, and one thing, especially in the obese patient, you might do a sleep study and look for sleep apnea.
Okay. Please reiterate the fecal testing that was mentioned in the beginning of the lecture. What type of test and what is the significance to diagnosis of diabetes?
Okay. The test is from Enterolab, ENTEROLAB.com. It's a lab that is specialized and created a fairly sensitive stool test. Patients can actually go online and do it themselves. They don't need a physician. Dr. Fine has established a low of 10 units. Below is normal, and anything above 10 units might have sensitivity to gliadin. And the significance is that type 1 diabetes, there's a high correlation with celiac disease. So, and in all autoimmune diseases. And in the research that we saw last week from the hyperpermeability, there's actually several physicians and research that say that, all autoimmune diseases, including type 1 diabetes, actually starts with increased gut permeability. So we know that one reason for increased gut permeability inflammation is if you have food allergies, and especially gliadin. So the loop to type 1 diabetes is well established. Our own experience has been that anything in the body which causes increased inflammation speeds up that slippery slope to type 2 diabetes. And we have just found in our clinic that higher than 30% of our patients are insensitive. So that's something we check in our diabetics, especially a diabetic who's been struggling. That we just talked about, you can't get the blood sugars, runs around 100, and no matter what they do, they can't get it down. Background of gluten sensitivity can be an important factor that's preventing the body from having normal insulin signaling and glucose transport and regulation. So our experience has just been to check for it. Again, you can do it very simply by just having the patient eliminate, do a modified elimination diet, and again, check the blood sugars and see how it affects the patient, and then work backwards to get a great effect.
Okay, I think this is 2 questions from the same person. They say that previously you indicated to half the medical food if GI SXS developed due to significant inflammation.
I'm sorry?
They mention here that you indicate to half the medical food if GI SXS developed due to significant inflammation. Physiologically, what causes these?
I'm a little confused by the question. Let me just try to piece it together. Maybe the person can resubmit it. But we talked about, especially with Ultra-Inflamex and some of the medical foods, that especially the ones with RIA, that some people can have increased GI motility, either one way or the other. They can have increased gas. They have some GI symptomatology. But what we found that if you start at a lower dose and work them up, they rate this very well. And the question is, what exactly causes it is difficult because it doesn't seem to be one specific. For example, if it was always gas, I'd say, well, we're doing something with digestion, something with bacteria. It's not. Sometimes it's diarrhea, and we even have one of the doctors here that gets constipated. So somehow it changes the physiology. The lining, it might actually decrease hormone we talked about last time called zonulin. So you get decreased permeability and and you may be constipated. It's hard to say. We have not come up with a single underlying cause for this phenomenon. But like in 90-some% of the patients, if you slow over to, they can tolerate full doses. Hope that's to the question that was asked.
Yes. We have a few more questions. Do you still have more time?
People that are will stay on. We'll go till the questions are answered.
Very good. Could you go over some of the alpha-glucoside inhibitors by brand name? Would you please explain the effect on carbohydrate metabolism? Is the result the patient passes the nutrients through the urinary or bowel system?
I really don't want to name them. We were told not to. But to the question, I think Actose. There's a couple of them. These products are normally added in a normal patient with diabetes. First drug would be metformin. Maybe you would go to rosiglitazone or several other of the drugs. And these have physiological functions on glucose metabolism once the glucose has been absorbed. But what this looked at is that in order for complex sugars or starches broken down into glucose, fructose, like for example sucrose is split into glucose and fructose, that takes an enzyme which is in the intestinal lining. And this is your glucosidase. It's the intestinal lining, and its job is to help break down the sugars, because sugars are transported directly through the enterocytes. They go in between. There's active transport and absorbed into the bloodstream on the other side. So these compounds, pharmaceuticals, were devised to let's knock out that enzyme. This enzyme again resides in the lining of the gut. So by knocking out these enzymes, the can't complete the digestive process of the starches and the complex sugars, and they get absorbed. The sugar molecule is too large, so it absorbed, and it ends up being a hyperosmolar problem in water is brought in and get diarrhea. Or the sugar feeds bacteria, which then ferment it and create gas. The question.
I believe so. Let's see. That question earlier, Essex asked, stood for symptoms. So mentioning that, you indicated to half the medical food if GI symptoms develop.
Yeah.
Yes. Okay. Very good. Do you use the C-peptide test when diagnosing the diabetic patient?
I don't, but that's a good way to see if they're producing it of their own. In other words, if a person is getting insulin, you can run the C-peptide test because it'll pick up natural secreted insulin versus insulin that they're taking either IM. We normally don't use that test in lab, but it's a good test. Somebody comes to you, they're on insulin, and the other lady asks, well, how do you detect? Well, you do that C-terminal insulin test, C-peptide test, and you see if they're producing their own natural insulin.
What product is the fermented black soybean tochi extract?
What is a cheat sheet, but you ask, is called Glucorest. Like gluco, R-E-S-T, Glucorest.
Very good.
And we've had a little confusion. Remember, this is a backup product. It's not necessarily meant to be a first-line product. It actually can be added to people that are on metformin or some of these other medications because it tends to have a sort of effect, but not as many GI side effects. So we actually have some medical doctors who are more traditional using this product rather than the pharmaceuticals.
Okay, and this one person asks a two-part. She says that you mentioned that they manage stress and improve sleep, wondering how. And she says also, I find many people cannot afford the full recommendation supplements. Any suggestions on how to get around this and it means is healing time?
Okay, so first question, what do I mean by stress reduction, sleep? Okay, so we tried before, maybe I can't remember this time, that when you don't get enough sleep, several things happen. One, you eat cytokines in the morning, but two, the study just showed it's increased hunger for dense food. That came out a couple years ago. Great study showing that when you get less than 7 to 6 hours of sleep, we immediately wake up in the morning hungry and we go for those donuts. And to me, this would be very important for somebody who's diabetic, both to decrease inflammation and decrease the hunger. Now, how we address this is very complex, and maybe we can do a whole seminar just on addressing sleep issues, but don't forget 90% of the time, lack of sleep is a habit. Start working on sleep habits. You look at room lightness. We might use a product that has some melatonin in it to help improve the natural diurnal cycle. We might actually do a saliva test at night to see whether there's too much cortisol and not enough melatonin, so we can address the sleep issues more scientifically. And then the other front, the stress part, a good program not only gives the person some type of relaxation mode, but in females, it sometimes gives them a pleasure that says no, so they take on more responsibility. It's about allowing people to realize that they need to take leisure time every single day for themselves, and it's okay, especially for a woman. I mean, okay for a man to get into his cave and chill out, but the wife is still making the dinner, taking care of the kids, and it seems like our society may cast an aspersion if the woman just wants to plop down and pick up a book and spend a half an hour reading in the middle of the day, and that's okay. We have forgiveness issues, so the reduction of stress, again, it's in our whole webinar. Maybe we can do it in the future. We also have a whole, you can go on Metagenics.com and look at the stress. There's a whole stress package about how to patients a test called the distress test and how to score it. It's an excellent package that you can get from the Metagenics webinar, and then it leads up to various products that you can get from the Metagenics website. And then you can go to Metagenics.com and look at the stress. There's a whole stress package about how to patients a test. There's a whole stress package that you can get from the Metagenics webinar, and then it leads up to various products that may help patients through acute stress events. And then we repeat the last part of the question because I talked too much, I forgot.
That's okay. Let's see. She finds that many people cannot afford the full rations.
So there was a reason and a rationale that I started every single one of our protocols with the first therapy approach. So patients right in the eye, and I say, okay, to a therapeutic style in your life doesn't necessarily take a lot of money. And that's where I would start. You start with an elimination diet, you start with adding exercise, and a lot of the stress techniques do not cost any money. And you put them on maybe one medical food and omega-3s. If the medical food is too expensive, I would put them on maybe some of the multi-vites or maybe the package for females or the package for men to get them started. But we're going to find most of my success is working hard on those environmental influences. And so that's what I would do. And I've had remarkable success with very complex patients without them having to walk out of my office with a basket full of nutraceuticals. I hope that answers. So go back to the basics. Get the patient to change their lifestyle, and you'll be successful.
We'll ask you one more question since it's 18 after the hour. So,
wow, it is.
Yeah, so type 2 diabetes, when, if ever, would you consider having the patient take insulin injections?
In personal experience, in a type 2 diabetic, them get off insulin. I personally, if I'm taking care of a type 2 diabetic, that would be taken care of, because the person would not follow a lifestyle change, I them and send them to another doctor. That's not the way my practice was. My practice was about about lifestyle change more than nutraceuticals. So if a patient can't, some patients might come into you in such a dire straits, and again, I don't have a hospital practice, that you might temporarily need insulin to blood sugars to a level that are reasonable. Have an acute crisis. But normally, I don't have to put patients on insulin. I have 2 diabetics I'm talking about.
Good. Thank you very much, Dr. Kornberg.
Well,
yes.
Appreciate everybody hanging in there for these 4. And, if you like this kind of format, please let us know, because this was the first of this kind of an approach, and something that made the subject easier, was fun. Please let us know so that we can plan additional seminars. Have a great week, and see you next time.